going to be very interesting talk, for a specialty like oncology. What is minimal surgery, and what is the outcome? Over to Dr. Mohan Raj.
A very good morning to one and all. Today, I'll just give a talk on what is the role of minimally invasive surgery in surgical oncology. What is the evidence and what do we practice and what we have seen in our experience. What is the current status of minimally invasive surgery in surgical oncology. Coming on to the claimed benefits, that is the advantage of minimally invasive surgery. Generally, minimally invasive surgery is associated with smaller incision, lesser scar and less post-op pain, which in turn leads to the early recovery and quick return to normal activity. All these contribute to the shorter hospital stay. These are all the benefits in terms of patient's aspects. With regard to surgeon, the minimally invasive surgery comes with improved 3D vision, increased dexterity and hand movements, especially in robotics where a 360-degree movement is possible, and better handling of tissues, which all these in turn lead to the decreased complication. These are the claimed benefits for minimally invasive surgery for any field. Looking into the flip side of the coin, the disadvantage of minimally invasive surgery is most of the time that requires special training and equipment, and operation generally takes a longer time. And the learning curve is also generally compared to open surgeries. For minimally invasive surgery, it's quite a longer learning curve. And not all patients will be fit for minimally invasive surgery. Patients with severe cardiopulmonary complications or cardiopulmonary morbidities may not be fit for minimally invasive surgery. And most of the patients, the cost is also additional cost is involved for minimally invasive surgery when compared to the open surgery. Coming into the topic proper, what are the concerns in oncology? What is the role minimally invasive surgery pertaining to oncology? What are the things we are concerned about as a surgical oncologist or as an oncologist? First and foremost is the margins for the primary tumor. Oncology, surgery should be performed with adequacy. R0 resection is always the aim for any surgical oncologist. We would not like to compromise on the margins. Next thing is adequacy of nodal yield. Both margins and nodal yield will give us the accurate TNM staging. All the further treatment and any treatment and prognosis or any patient is dependent on the accurate TNM staging. Most operatively, even though we have a pre-op TNM staging, the post-op histopathological staging is found to be more useful and more accurate. So that decides the adjuvant, further treatment and prognosis of the patient survival. So we would not like to compromise on both the margins and adequacy of nodal yield. And few concerns like port site recurrence, local recurrence, and duration of surgery is generally prolonged in an already compromised oncology patient. And the more worrisome is that overall survival and DFS should not be compromised. With regard to oncology, we are more worried about the survival rates than the modality of surgery. So, minimally invasive surgery generally it is of three approaches: laparoscopic approach for abdominal surgeries, thoracoscopic approach for lung surgeries and mediastinal surgeries, and robotic surgeries. I would like to narrate based on the organs, what is the evidence and what do we practice and what we have seen. First, I will start with gynecological cancers. Of the gynecological cancers, there is a role for minimally invasive surgery in endometrial cancer, cervical cancer, and ovarian cancer. For endometrial cancers, most of the endometrial cancers present in early stage. Because patients present with postmenopausal bleeding PV, majority of endometrial cancers in India and in abroad also, they present to us in stage 1. So minimally invasive surgery is a preferred method. There is various studies and various trials have proven beyond doubt that minimally invasive surgery is equivalent to open surgery, open staging laparotomy in terms of both survival rate and recurrence rate. So, and the advantage, especially in endometrial cancers, is most of the patients of endometrial cancers are obese, and hence minimally invasive surgery is definitely advantageous that would help them in shorter hospital stay and early recovery, early mobilization, which in turn further decreases the risk of DVT. So, for endometrial cancer, minimally invasive surgery is definitely the preferred method. It can be either a laparoscopic approach or a robotic approach. Both are equally advantageous, and for endometrial cancers, minimally invasive surgery is recommended. And the indocyanine green, which is now increasingly used for sentinel node technique, minimally invasive surgery is preferred method. But in contrary, for cervical cancers, the evidence is not for minimally invasive surgery. Previously, even for cervical cancers, people used to do radical hysterectomy by laparoscopic or robotic approach. But the latest evidence, the large randomized trial called LACC trial, laparoscopic approach for cervical cancer trial, this was published in 2018 by Ramirez et al. Here, they compared the minimally invasive approach, both laparoscopic and robotic radical hysterectomy with open radical hysterectomy. And they found that minimally invasive surgery is associated with decreased overall survival and disease-free survival when compared to open radical hysterectomy. This decreased survival rate was persisting even after adjusting the age of the patient, stage of the disease, everything, and tumor histopathology. After adjusting everything, laparoscopy or minimally invasive approach was found inferior to open radical hysterectomy for cervical cancers. So the current evidences for cervical cancers, the radical hysterectomy, which is the standard surgery that is done for cervical cancer, minimally invasive surgery is evidences against minimally invasive surgery. Even now, the open surgery is preferred. Coming on to ovarian cancer, to be frank, ovarian cancer, the laparoscopy is not that much beneficial. Mainly, it is used in diagnostic purpose. Because most of the patients with ovarian cancer, they have a tendency to spread through the peritoneal. Metastasis is more common and peritoneal spread is more common. So it's always better to put a diagnostic laparoscopy for most of the ovarian cancer patients to assess the operability, to know the extent of the disease. Especially even now the current evidence is even for stage 3 ovarian cancer patients, there is a role for cytoreductive surgery with hyper. So all this can be well planned in advance if a diagnostic laparoscopy is used. And the therapeutic for ovarian cancer, the role is not clear. As I told, most of the patients have tendency to have peritoneal deposits and to do adequate peritonectomies, especially subdiaphragmatic peritonectomy, Morrison's post peritonectomy, pelvic peritonectomy. Minimally invasive surgery is not that much helpful. So currently the role of minimally invasive surgery for ovarian cancer is mainly diagnostic. The role in therapeutics is limited. Now coming on to how to deal with an adnexal mass or an ovarian cyst, the scenario that commonly encountered by any gynecologist or commonly encountered by gynecologist. Most of the time, what will happen is a patient presenting with the adnexal mass or ovarian cyst will be dealt with by minimally invasive surgery or laparoscopy commonly, and the final histopathology will be presenting as malignancy, and they will report to us. Why there should be a caution? Before we are not telling that laparoscopy should not be attempted for a patient with ovarian cyst or adnexal mass. But before attempting, there should be a high index of suspicion for malignancy, and the features of malignancy should be ruled out. So that after ruling, why? Because because if a tumor is confined to ovary and if it can be treated or if it can be removed without rupture, the adjuvant chemotherapy can be avoided. And if we are not able to completely remove the tumor, or if there is any intraopsil, especially this will happen with adnexal mass or ovarian cyst, because most of the patient present with a 20 to 30 centimeter mass, which will be very difficult to deliver through the laparoscopic ports, and we end up spilling the tumor or leaving behind the tumor. If that is the case, then the patient is upstaged from stage 1A to stage 1C, which in turn becomes an indication for adjuvant chemotherapy. The patient will be unnecessarily going through the side effects of chemotherapy. In oncology, any treatment will come with side effects, there is no doubt. But we should just think before whether it is needed for the patient and whether it should be given. So if the patient is upstaged because of tumor rupture or tumor spill that is happening because of a minimal invasive surgery, then that can be avoided. For that, now any patient who is presenting with adnexal mass, there should be a high index of suspicion. So these are the few indicators, or these are the few guidelines which might be helpful. Not that all patients we can accurately predict, but by using these predictors, we can somehow predict that which are the patients who are likely to have malignancy. Presence of gross ascites, elevated tumor markers like CA125, CEA, beta HCG, LDH, AFP, inhibin, serum inhibin, presence of elevated tumor markers. And nowadays, radiologists have started giving scoring for most of the masses, ovarian masses, like previously for breast only they were giving Virat scoring. Now for prostate, ovary, kidney. For most of the cancer, they are able to give a ovarian. This is ovarian reporting and data system for ovarian neoplasm. Any neoplasm scoring of more than or equal to 3, they have a well set criteria of how to give a scoring. ORAD scoring, like BIRAD scoring, this is a ORAD scoring. For ORAD scoring of more than or equal to 3 is that, then it's always better to consider for an open approach. Presence of peritoneal and nodal deposits, and also a lot of scoring system is there. ROCA, risk of ovarian cancer algorithm, risk of ovarian malignancy algorithm, ROMA, and risk of malignancy index. A lot of scoring systems are available. So based on this scoring system, any surgeon can have an idea about what is the suspicion or chances of malignancy in the final histopathology. Based on that, they can decide on whether to opt for an open approach or for a minimally invasive approach, either through laparoscopy or a robotic approach. It's not that all adnexal masses or ovarian cysts should be dealt with open approach, but before taking the patient for surgery, we should have a clear idea that how much is the chance of malignancy. Is there a chance for tumor spill? Whether we can be able to deliver the specimen through by putting a intraretrieval bag like that. Based on that, we can decide what is the approach to be decided for an adnexal mass or an ovarian cyst. Now coming on to the next site, that is thoracic cancers. Video assisted thoracoscopic surgery, VATS, is a preferred modality of choice for most of the lung resections and mediastinal tumor resection. VATS has been proven beyond doubt that it is superior to open surgery, because most of the thoracotomy incisions are painful, highly painful. This in turn will prevent the patient's recovery. Patient will, because of long big thoracotomy incisions, patient will not be able to breathe properly in the post-operative period. Patient would have already undergone a lobectomy or pneumonectomy. If he is further not breathing, then lung function will get compromised. His oxygen support will be more. So definitely, video assisted thoracoscopic surgery by a lot of clinical trials has been proven beyond doubt that it is superior to open thoracotomies. So VATS is a modality of choice without doubt for lung lobectomies and pneumonectomies for lung cancers when indicated. That is for operable lung cancers. Now moving on to the urological cancers, kidney. For kidney also, minimally invasive radical nephrectomy is equivalent to open radical nephrectomy if appropriate case selection is done. Generally, tumors less than 10 to 12 cm in size, which are confined to gerontophagia, without adjacent organ involvement, and presence of renal thrombus, renal vein thrombus, or IVC thrombus is not a contraindication for minimally invasive surgery. But if the IVC thrombus is extending up to the infrahepatic IVC, intrahepatic IVC, then we should think about whether we will be able to manage it with minimally invasive approach. Generally, patients without extensive nodal involvement, patient when they satisfy all these criteria, then you can plan for a minimally invasive radical nephrectomy. Minimally invasive radical nephrectomy has been proven to be equivalent to open radical nephrectomy. And moving on to prostate cancer. Of all the cancers for minimally invasive, prostate cancer is one cancer where minimally invasive surgery is definitely advantageous. Because prostate is situated in one area, it is deep in the pelvis, where even anatomical approach, access by open surgery, everything is difficult. So definitely for prostate cancer, minimally invasive surgery is definitely advantageous than an open surgery. This prostate, especially in prostatectomies, minimally invasive approaches have the advantage of improved nerve preservation, preventing impotence, urinary and fecal incontinence, which a patient doesn't want to have after an radical prostatectomy. And especially robotics, improved vision is there, easier access is there for the structures, and decreased blood loss. So for radical prostatectomies, minimally invasive surgery is superior, especially the role of robotics. Pelvic surgeries, especially prostate surgeries, pelvis is one area where robotics is definitely superior compared to laparoscopic, even compared to laparoscopic and open approaches, because of limited operating space, improved instrument articulation that is available in robotic approach, and magnified 3D view. So for prostate cancer, minimally invasive approach, especially robotic prostatectomies, are definitely advantageous over lap and open prostatectomies. Coming on to GI cancers, the current textbook standard is that any patient with GI cancer, diagnostic laparoscopy should be performed to assess the operability, because up to 10% of GI cancer has been found to be inoperable after making an open laparotomy incision, and they are found inoperable. So all patients with GI cancer, the current textbook recommendation is to go ahead with a diagnostic laparoscopy. Minimally invasive surgery for definitive surgery, that is for definitive treatment of GI cancer, should be based on the site and extent of the tumor. Coming on to the stomach, there are a lot of clinical trials have been published. To mention a few, CLASS, JCOG, CLASS, all these have proven that minimally invasive radical hysterectomies are increasingly being performed based on the results of all these trials. But what we feel in our experience is the adequacy of D2 nodal dissection, because D1 versus D2 nodal dissection has been proved beyond doubt that D2 nodal dissection has a 10% overall survival rate benefit. So whether we will be able to complete the D2 nodal dissection in minimally invasive approach is still debatable, even though the trials and evidence favor minimally invasive surgery for radical gastrectomy with D2 nodal dissection. The adequacy of D2 nodal dissection, we are still not yet convinced. And of course, this like I told you, the surgery is not done properly in oncology, it will in turn affect the patient's survival, and which in turn increase the recurrence rate for the patients. Also for colorectal cancers, also a lot of trials have come up, like COST trial, classic trial, collar 1 and 2 trial, rollout trial. All these trials have proven that minimally invasive surgery is equivalent to open colectomies or open rectal resections in terms of the recurrence rate, disease-free survival, and open survival. But generally, what even these trials tell us, this minimally invasive approach is not indicated for obstructed tumors, perforated tumors, and for T4 tumors. What we have seen in our experience is that rectal cancers, we do not have any issues with minimally invasive surgery. We routinely perform laparoscopic abdominal perineal resection and low anterior resection. But colon cancers, what we have observed in the few cases we have done, and few cases that have been referred to us from other centers where minimally invasive approach is practiced, is there is an increased rate of port site recurrence and peritoneal recurrence. What we have seen is that patients who have undergone minimally laparoscopic hemicolectomies and laparoscopic subtotal colectomies present with increased site of peritoneal deposits, that is abdomen confined disease. It is not that the patient has a disseminated widespread metastasis like lung mets, liver mets. We don't know the exact cause, but evidence is for the minimally invasive surgery. But what we have seen in our experiences, colon cancers, when approached by minimally invasive surgery, laparoscopic colectomy, we have seen increased port site and peritoneal recurrences. So currently we don't practice minimally invasive surgery for colon cancers. So summary of what we do here, that is for minimally invasive surgery at our hospital, is we do diagnostic laparoscopic staging for endometrial cancer, laparoscopic low anterior resection, abdominal perineal resection for rectal cancers, laparoscopic radical nephrectomies, laparoscopic ovarian cystectomy, and laparoscopic salpinging oophorectomies. All these surgeries are being performed at our hospital in the Department of Surgical Oncology. So I just want to put a word of caution that what a surgeon should think of deciding a minimally invasive surgery for a surgical oncology is that we should ensure complete primary tumor removal with adequate margins, which is of utmost importance in treatment of any oncology patients. The nodal dissection should be adequate because there is a standard criteria for each site. For for example, if it is a colon cancer, 12 nodes has to be retrieved. If it is a esophageal cancer, 16 nodes has to be retrieved. If it is a stomach cancer, at least 15 nodes has to be retrieved. If a pelvic lymph node dissection is done, at least 7 nodes has to be retrieved. So adequate nodal dissection. This adequate nodal dissection will give us the exact tumor staging, and which in turn will help us to get the adjuvant treatment. Whenever possible, it is better to avoid the tumor rupture and spillage. This can be achieved by retrieving the specimen. There are special bags for specimen retrieval bags that has to be used, and to avoid port site contamination, there are preventive bags there. All these should be used. So whenever in doubt that whether we will be able to completely remove the tumor, whether the tumor will be removed without whether R0 resection will be possible, then it's always better to convert the surgery to open surgery without any extensive. So the take-home message is that there is no doubt about the advantages of laparoscopic approach or laparoscopic or robotic approach based on the evidence. Most of the evidence on most of the sites, the laparoscopic minimal invasive approach is equivalent to open surgery. But as an oncologist, we are more worried about the tumor clearance. That the tumor clearance is utmost criteria that has to drive a surgeon to decide between the minimally invasive approach and the open approach. Always and one more important thing is whenever planning a treatment for a patient, whether to go for open invasive surgery or minimally invasive surgery, cost factor should always be considered because surgery is not the end of treatment for any cancer patient. Patient will further need chemotherapy, radiotherapy, targeted therapy, and his resources, financial resources should be saved enough to take care of everything. In cancer, we are almost, generally there is a thought that surgical oncologists are apprehensive about minimally invasive surgery. It's not like that. In cancer, we are more worried about patients' long-term disease-free survival and overall survival than having a short-term advantage of pain-free, shorter, comfortable post-op period. As a surgical oncologist, we are always more worried about the cure of the patient than the scar of the patient. Thank you.
Thank you, Dr. Mohan. For a nice talk. So it ended up like, in the pro-con debate, you are on the con side.
So it's not actually we are on the con side, we just want to be cautious, that's all. It's not that, like I told, we are not against minimally invasive surgery, but the patient selection criteria and tailoring for each patient is of more important than offering minimally invasive surgery for every patient.
So comments, so Karthikeya sir. So we do understand we cannot extrapolate minimally invasive surgery of non-cancer indications to cancer indications. So your comments.
Definitely in oncology,
Because we are very much worried about the pathological staging than a pre-surgical staging, because it totally differs in terms of.
definitely in oncology, as far as the patient survival and the cure, utmost important rather than the short-term gains with post-operative pain recovery. More than that, oncological principles should be followed. That's the main concern. So whether we can practice with minimally invasive surgery, that is the question now. So probably only area where we face problems is only the colon. Even rectum, we are okay. All other things we are doing with minimally invasive. But problem is patient should be affordable. Tumor should be accordingly. So patient factors, tumor factors, many factors should be taken into consideration before choosing the modality.
I think Mohan Raj put it right. The only message is, Dr. Loganathan, we should not take lab too easy in oncology. That is the thing. See, after we have been tailoring and Karthikeya has been doing it over a period of time, and despite that, we found our colon cancers to have recurrences. That really made us think that we should not, just for the sake of pushing through a surgery, all our patients are open to, whatever we convey to them. If we are going to say open surgery, they would take it. Okay, maybe gradually there will be a shift to people asking for only lab. Okay, the thing is, it has to be over a period of time, it should be short steps at a time, because it means 100% for the patient. We might say 40% recurrence is too high for us, but for the patient it is 100%. The other thing is, why you think that we are barefooted is, the adjuvant treatment is phenomenally good, and over a period of time, we keep talking that, chemo and radiation might even replace surgery in so many other fields. It's already done it, and maybe, radicality is grossly coming down.
There in stage 1A, one cancer, so they compete with you.
Okay, so, that is the reason. We don't operate on prostates. It's not because we don't want to do. They don't need it. Do you understand? So, we go only by proper indications when you have to operate. Given the fact that most prostates will outlive the disease. But if you want to do your procedure, you can still do it. But that's not the right thing, isn't it? And radiation does phenomenally good job in prostates. Okay, so that is why, our esophagus rates are much lesser. But our survival rates in esophagus is extremely good. Chemo does fantastic job. And that is one reason that we don't operate on esophagus upfront. So, that is the reason that the numbers may not be big and we appear to be back-footed. That is because we want to be holistic in treating the patient, give them the maximum survival benefit with the least bit of functional dysfunction.
No, rightly put, madam. So it cannot be generalized because the site matters, disease extent matters, stage matters, and the indication matters, comorbidities matters. A lot of things. Any more comments? So whatever thing is, so it needs more
patient-based, disease-based, tailored approach.
exactly, sir.
That's what.
A question to the oncology team is, as far as the vast thoracic surgeries are concerned, for a resectable lung cancer, what is the percentage of the disease being upstaged after the surgery without being a pre-procedure illness?
We don't have a proper data. Because we operate less on lung cancer.
Yeah.
Right?
So yes, but because you said the data is very strong as far as the thoracic surgeries are concerned for a resectable lung cancer.
Agreed.
Maybe less than a 2 year or like that. But thing is, the contralateral nodes will be missed. Because incidental, for example, tumor, small tumor, 1 centimeter tumor, 8 millimeter tumor in the right upper lobe, patient can have a contralateral disease, N3 nodes can be positive, N2 can be negative. So my curiosity is to know what is the upstaging of disease after thoracic resections for secondary to VATS surgeries.
I think now most of the patients we do a pre-op EBS. Now most of the patients we do a pre-op EBS. Based on the pre-op EBS only, we take up the patient for surgery.
What is like certain area where we are focusing more? Every child you encounter is a divine appointment. International Childhood Cancer Day was observed on February 15th, and that's why we took pediatric oncology this time as the topic. So dedicated pediatric radiotherapy units is an essential component of high quality childhood cancer services. Access, demand and quality of pediatric radiation oncology vary widely between centers according to the location, availability of both technological and human resources. So what this actually means is access to external beam radiotherapy machines is limited both in terms of number of machines available and their geographic locations, which makes patients travel long distances and stay away from home too. So for a child, imagine they are out of their native places and they come here, stay for a long time. Radiation therapy, generally the duration is minimum of 25, 30, 35 days. That means without Saturday, Sunday, it is more than 6, 7 and 8 weeks. So around 2 months, they will be out of home if they are from too far away places. If they are nearby or maybe in and around Coimbatore, then they come and stay from Monday to Friday with us, and then Saturday, Sunday only they are back home. For adults itself, we see psychologically they are not okay with staying in the remote places, even for us. But for a child, maybe from 2 years, we treat even 1.5 to for rectoblastomas, and for till 10, 12. Those children who are psychologically, they won't be going to school, they won't have a peer, they won't have friends here, and it is such a very depressing atmosphere. We should see the environment. It is very stressful for any kid to be very much normal in the atmosphere. So vast data analysis has led to refinement of role of radiotherapy in pediatric tumors, leading to reduction in dose and or volume. So initially when we started, like say SRIOR is already 20 years old, but the data for pediatric oncology, say 50 years before, what we've been doing is only 2D, like large fields we used to treat. So the morbidities induced by radiotherapy was held. So how we can do this? The indication of radiotherapy relies on risk-adapted strategies. Now we are moving on to refinement, like how surgeon is moving on to minimally invasive. Like we are moving on to minimal or reduction of field sizes, so that the volume of the normal tissue inside the irradiated area is less. So that is where the risk strategies come up. So for most of the pediatric tumors now there is the risk strategies in which the cases are grouped into low risk, intermediate risk or high risk. So according to that, the dose and the volume of treatment changes. So the risk adaptive strategies incorporating integration of chemotherapy and its responses, as well as improvement in surgical techniques. Moving from conventional 2D. So in 2D days, we used to give just an APPA, which a large field, no MLCs. So the open field will give lot of dose to the surrounding normal tissues. Say for example, if I am treating the spine. So we used to give just an open field, just a rough measurement with the X-ray, and it's only an X-ray guided. Even those days, image guidance was there, but it was only X-ray. There was no volume-based planning for radiotherapy. And from there, we have moved on to 3D conformal radiotherapy, and then to intensity modulated radiotherapy, and now we have moved on to stereotactic era. Now all the techniques which has proven to improve outcomes with less morbidity. Why? Why we are so worried about reducing dose volume? Because radiotherapy is a treatment using ionizing radiation. Ionizing radiation means it can ionize whatever cells in the body. And human body, it has multiple cells. The majority, 80% of human body is water. And what we need for ionizing radiation to cause the change, or we call it as indirect action of ionizing radiation, is it interacts with water, reduces hydroxyl ions, and then it causes DNA damage. So this same mechanism happens not only in the tumor. So imagine radiation or X-ray cannot identify this is a tumor cell, this is a normal cell. It is just X-ray. It just enters, it exits. So it causes destruction. So that is why we are more concerned about protecting the normal tissues. So we know very well it is a double-edged sword. We are using only the good side for the reason this is the mechanism of action of how X-rays cause destruction. So it is an indirect action, and you have DNA damage and enormous side effects. See, so many, because X-rays are known to cause destruction. Why we are using this? Because it has a good side. It can treat tumors. It is a very good tool to kill cancer cells. But at the same time, we have to give so much importance to the surrounding normal tissues. So site-wise, say if we treat whichever site we are treating, according to that, the side effects will also change. And what are the commonly seen pediatric tumors in SRIOR? Generally, we see leukemias. When we have a dedicated pediatric ward, and in leukemias, the role of radiation oncologist will be prophylactic cranial radiation. And in lymphomas, after chemotherapy, the residual lesion, or even in early stage, we do give involved field radiotherapy, which is a curative cases. Retinoblastomas, very small kids, we have seen most of the children either nowadays it is after we are trying to preserve the glow. Initially it was they will come with enucleated orbits, and either there will be a prosthesis in it or no prosthesis when we started here. And most of our patients will be from Urban Hospital, and we used to irradiate the orbits. Even in these situations, the young bone we are exposing to radiation, we see facial asymmetries is possible, long duration. If they survive, definitely retinoblastomas will survive longer, so they can live to develop secondary malignancies. But now the protocol has moved on again to even preserve the globe. So initially it was saving life, and then it was saving the globe. Now even we are thinking of saving vision. See how much evolution has happened. And now central nervous system, again the most common tumors we see, like most of pilocytic astrocytomas, like medulloblastomas, all these. And in medulloblastoma, the fields are very large. Like we treat whole of the brain, whole of the spinal system, like we call it as craniospinal irradiation. So it's a very large field, and imagine if we do a 2D, again how much of normal tissue will be irradiated. And then we moved on to 3D, and now we have started intensity modulated radiotherapy even for the larger fields. And the other cases are rhabdomyosarcomas, Ewing's sarcomas, or Ewing's group of tumors. And from a radiation perspective, how do kids differ from adults? Is it not the same? Like what are we planning for adults? The same thing we do for kids. But it is not the same, because the diseases which occur in kids are a little different. They are coming up with a lot of curable cancers, and so they survive longer. And we are more worried about late effects of radiation exposure. Techniques of radiotherapy matters definitely here, because if we go for the older techniques and if they survive longer, they will be seeing all the morbidities of radiation. And again, need of anesthesia. For an adult, for us the planning is very simple. If you ask them to lie down, they will lie down. For a kid, it's not easy. It is never so easy. So we used to struggle for a kid just to make the kid lie down on a couch, and then just to make them understand what are we going to do. So time is so important. And how is radiotherapy delivered? It's a very long process. It's the same when adult or a pediatric case is concerned. The planning process starts with immobilization first in an adult patient. But here, in a pediatric patient, sedation comes first, because the child will not lie still. And very important is no movement. The first step in radiotherapy is that the patient should be immobilized in the treatment position, and in that position the patient should lie down even for the planning process and in the treatment couch, so that for 2 or 3 minutes at least till the delivery of treatment is completed, the patient should be on the same position. This is possible for a grown adult. But imagine you are treating a 2-year-old or a 3-year-old. We just tell them, please lie down. Is it easy? Will they lie down? No, we give them chocolates, we coax them. Sometimes they cry non-stop. It's not, for adults, it's fear of unknown. They don't know why are they fearing. But still, whoever enters cancer department, in especially radiation oncology department, they will have fear. They can't even explain for why they are fearing. But for kids, it's actually simple. Because they have fear, they don't know what is cancer. They don't know what is mortality, morbidity. They don't understand all that. But they have just fear of strangers, strange place. That's all. So 1 or 2 days, if they get accustomed. So what we are trying to do is give little more time for a pediatric planning. So first thing is sedation, because the child has to lie still. And next is we go for immobilization, and then simulation, which is olden days it was X-ray, now it is completely CT planning in Sriya. And in planning, we have moved on completely from 2D. It is most of the time 3D and high precision radiotherapies. Sedation versus anesthesia. Again, sedation is mild, say we can even sedate a child giving a pedicure. But in oncology, see it is 19 or 20 years since we are now, I have never seen a child sleep with pedicure. So they just come with so much of apprehension. Even with injections, we have seen kids getting up along with the remobilization cast. We have seen so much of, they will be so much awake, they will be so scared. So it's like sedation and anesthesia, we don't know, it's like some children are okay. We have seen at the same time children who without sedation also they lie down. We have seen 3 years, 4 years, they still understand. So we see extremes of kids, either this extreme or that extreme. So sedation or versus anesthesia means it's like some kids definitely need anesthesia support. Who needs it? Anyone who can't lie still, almost all kids, that means less than 5 years old, and few kids even older than 5 years sometimes. And maximum sedation is necessary for us when we, in the first day, especially when we do the cast and we do the planning CT or planning imaging. And the subsequent treatment days, usually they get adapted to the surroundings, to the technologist and the treating team. So in few days, we have seen most of the patients not even require sedation. They come, they lie down, they know very well we are not injecting them. First thing they want to know is, are they getting injected? If no injections, they are very happy. So 2 to 3 days, they'll be very adamant, and 4th day, 5th day, as we move on, in a week's time, most of the kids will get adapted. But we had one kid, like, this is the advantage of moving on to from 2D. The first image is the conformal radiotherapy. It's not even a 2D. We have not put 2D images at all. This is conformal radiotherapy. The first, a retinoblastoma. Like you can see how much of those is going to the brain. And from there, moving on to MRT. And then we have the VMAT, which is the latest one, which we use for most of our patients. Treatment process. Again, on the treatment couch, the child has to lie still. So because with the same immobilization cast and in the same treatment position in which the planning CT was taken. And then we used to image them because our machines are having inbuilt CT scanners. So we can image and we have to match it and we find out whether there is any error in the setup or it is perfectly matching. If the match is perfect, then we move on for treating the case. So this is the treatment setup, and next step will be treatment setup and delivery of treatment. And very important is the quality assurance, because we are machine dependent doctors. Like our machine should be pakka. So every Saturday we do a quality assurance program so that the machine is perfectly functioning. Because depending on the machine, we are treating so many patients. So that is a very, very important program in radiotherapy units. And the very important thing, children need time. So they need time in the planning process, they need time in the first day on the treatment machine, so it is not easy. So when we tell them 30 days of treatment, weekends off, we have to give extra 3 or 4 days or 1 week time for the kid to get adapted to the environment. This child, for all the 30 days, he required anesthesia. And here I would like to thank the anesthesia department. Every day, 8 to 9 was the time allotted for the medulloblastoma child. They used to be there sharp at 8 o'clock, and sometimes the kid will get accommodated by 8:15. Sometimes it will take 8:20, sometimes 8:30. But even the setup is done at 9 or 9:15 or 9:30. They've been all through the 1 hour, and they will be monitoring the kid. And it was not easy with this kid. He all 30 days, I've never seen like this. This is the first time all 30 days giving IV propofol for this kid. And every day he used to get adapted to the dose. So they were giving slightly higher doses. It was a stress for the whole anesthesia department. Even for them it was really challenging, not only for us. So treatment setup, this is what we did for the craniosspinal RT child. So this is the setup. The child is with the aquaplast. You can see he is tied to the couch even with on the backlock. That's the immobilization device on which the child is lying down. And then with all the tubes, you can see one is the IV flow of propofol, and then we have the pulse oximeter monitoring. And from outside, the anesthetist used to watch, which we have monitored with the CCTVs, and they can see the monitor very clearly, and we monitor everything from outside. If the child moves, then we stop and we go in. Again, they have to push in more drugs, and then we have to come back. Again, we have to re-image because if the child is moving, and then we adjust. Again, we reset, and then only we treat. So all 30 days, it was the same for this child. And so that's how, so this is the part which we wanted to insist. So in children, it is whenever a child is referred to us, it is not the same day we plan, we immediately jump to treatment or the next day. It is not like adults. So pediatric radiation oncology is very challenging, and even from day one, it is a teamwork. Our technologist and our physicist and the whole team has to work beyond a child. So it is so important, and the time management is so important. Sometimes they will ask the treatment is still not started. And more important is the counseling of the parents. Here it is not only the kid, because kid doesn't understand anything. It is easy to handle the kid actually. It is the parents where we take more time to counsel. Sometimes they will stand outside the treatment machine keeping on crying. So it is very tough. We'll ask the mother to talk to the child in the mic so that the child will hear their voice. Sometimes it will make the child very annoying. Sometimes the child will calm down. So it is a very long process. So this is what we wanted to tell. And the other thing is like what we are doing is breath hold techniques. Now, who needs the breath hold techniques is left-sided breast cancer patients. Of course, not all patients require this, but most of them, because there is advantage for this. Why we do this? To reduce heart dose, to have a reasonably acceptable lung dose. When a person holds breathe, the lung capacity increases. So in that situation, of course, the heart will be away from the chest wall, but the lung volume is increasing, so lung portion might be a little more. So we have to balance both. Those constraints which is given by our contact guidelines is lung V20, that is volume receiving 20 gray should be less than 30%, and the central lung distance should be 2 to 2.5 centimeters. And for heart, the mean heart distance should be less than 1 centimeter. The mean dose received by heart should be less than 5 gray. Volume receiving 12.5 gray should be less than 5%, and volume receiving 250 centigrade should be less than 30%. Who are the right candidates for this? Generally what we do, we ask them to hold the breath in the clinic, so that are they holding the breath at least for 10 or 15 seconds, like that's called deep inspiration. In the deep inspiration, if they are holding for at least 15 seconds, we right away take the patient for planning. But if they are not holding like 10 to 15 seconds in that category, we teach them breathing exercises like pranayama, and we train them, we ask them to come back after a week's time, so that we reassess them. If they are holding it better, say they again move on to 15 or 20 seconds, we right away take them for planning. If they are still doing only 10 or lesser, we put them in the free breathing, and we don't advise the breath hold for them. This is the images of the same patient. The first one in which we have planned is the breath hold, and the other one which is showing the free breathing. So that you can see the lung volume is different because lung is enlarged and the heart is moved away from the chest wall. Actually, we have equipment dedicated for this. It's called the active breathing coordinator. So active breathing controlled by patients voluntarily. So the advantage of this machine is the machine can monitor the deep breath hold, and it can the beam will be on only when the patient is doing breath hold, and the beam automatically switches off when the patient expires. So, but we don't have this, we are still doing it manually, which definitely, it will be prone for some errors. So these equipments are available, say, for past 5 to 6 years. In slowly, lot of centers are taking it up. It is so useful because it can be done automatically. The beam switch on and switch off is automatic, and the machine controls it. But for us, we have to do it. The patient has to give a sign if they are expiring, so that we have to stop and the technologist has more time on the machine. And then the technologist has to monitor again through the CCTV, looking at the patient, and the patient has to say okay, and the patient has to say no, and then it is like communicating with the patient. So what we still want to do this because there are definite advantages. We are able to reduce the heart dose. All 3 parameters achieving is very tough in free breathing. Even in free breathing, we are able to reduce the mean heart dose in most of our patients. But we have 3 criteria in heart, all 3 cannot be achieved with only free breathing CTs. But in DIBH, we are able to achieve all 3. That's the beauty of doing this technique. So again, I want to add one more thing here, because we have integrated this also to all our patients. And why we are doing this? Because there are a lot of benefits for exercise and yoga, and as a team, we feel it is not only counseling the mind, and it is not only treating the cancer or the body, we have to counsel the mind also. Because most of our patients is like they are coming in with a lot of depression, and that reflects on the outcome, and that reflects on the way how they take up life after cancer diagnosis. It's always a chapa that they are cancer survivors. And even after treatment, say we are seeing them after 3 months, sometimes they come back with the same look, and they don't even come out of the field that they are like, okay, the treatment is over. But we as a team, we feel it is not like insisting on only treatment of cancer, or it is like, okay, you're disease free, that's it. But that's not the point. They have to live life. So what are we giving them? Are they really going back to their original life? So we thought, why can't we do something more to our patients? So now we are teaching them, or at least advising them to go for some yoga classes, and taking up some kind of sport or exercise, so that and these are proven with a lot of papers. These are presented in our own national heroic conferences. What are the benefits of yoga introducing in cancer patients? So it reduces fatigue, improves sleep disorders, reduces anxiety, first of all, and urinary incontinence, especially when we treat pelvic patients. And positive thoughts, that's very, very important for a cancer survivor, and especially pranayama in lung tumors. This we have to thank the PET scan department, because after the PET came in, we were able to see what radiation is actually causing. So we could see the pneumonitic changes in the radiation fields. And slowly what we thought, okay, introducing the breathing exercises, and we are checking with our PET department, so that how is it? The pneumonitis, the percentage of pneumonitis is much lesser for patients who are seriously practicing it. It is our duty to teach, but the patient has to take it up seriously and do it. Most of our breast patients, our esophagus patients, and lung patients especially, we definitely make it a point to teach the breathing exercises, so that after the treatment, when we reassess the patient on a PET image for volume assessment, we do assess the pneumolytic range also. So it's good that we are able to see the change, and we definitely feel it is a positive move. So that's what we wanted to tell you all today. Thank you so much.
In rehab,
Exactly.
I'm sure government would have been happy by seeing that slide. This is in the lighter sense. So before my question, government sir.
We have lots of problems. If it's a single lesion or multiple lesions, primarily lymphoma brain, and recovery rate, as far as you're concerned, seems to be not that good.
Yes.
Not that good. And second thing, if you want to radiate, how to radiate multiple lesions?
Sir, generally for primary CNS lymphoma, the protocol itself is only whole brain. We never give a focused treatment. Even if it is a single lesion, the guidelines is to give a whole brain radiotherapy, because what we are visualizing is a single lesion. But generally, because it is a blood disorder, we expected it to be in the microdeposit in the whole brain. So primary cranial lymphomas, the protocol itself is to treat only whole brain, sir. We never give focal.
In what instance of
The
radiation?
prognosis is actually very poor, sir. So the patient will not survive that long to find out. Like first of all, the progress of the disease is very fast. We have seen most of patients they fail.
We had one patient, this primary lymphoma brain, and when we told all these things, they were not happy, very unhappy. So they went off and went for native treatment and yoga therapy. 3 months or 4 months later, they came back telling, I'm all right, everything is cured. I was surprised. Where's the cure? Probably the native medicine, what they were taking, content was steroid, plus yoga. Of course, steroid helped.
Definitely, sir.
And luckily, sometimes very rarely, spontaneous recovery. That would have happened. So the steroid, yoga, and the spontaneous recovery. Yeah, I had seen only one such patient. But most of the patients, what I had seen, primary lymphoma, ended up the mortality
Very high, sir. Very high. True, sir.
So, I think there are the protocols in radiation oncology for a moving lung tumor to irradiate. When the lung moves, when the normal tissue comes, the machine stops. When the lesion comes, machine delivers.
Exactly. So those days, like initially,
Yeah,
we used to have, we need a 4D CT for doing all this because we need that for planning and then we have to execute it on the machine. But in Tomo, the beauty is we don't need a 4D CT. Because there is a software called Synchrony which does the same movement gating straight away in the machine and then we can do a free 3D seating as well.
So, as a surgeon, as a surgical oncologist, what is your challenge when you send the patient to radiation oncology after surgery?
Basically, oncology it's a multimodal treatment. See, we have to incorporate most of the situations, we have to incorporate all the 3 modalities, and the timing and sequencing is very important in incorporating all the 3 modalities. See, sometimes, like the timing, for example, if you do a surgery within 6 weeks, we have to give the adjuvant treatment, whether it's chemotherapy or radiation. If we have any surgical complications, then we are stuck. The wound complications, the patient is not recovered, the general condition is poor, we can't start chemotherapy, then we are stuck. It definitely reflects on the survival. So timing is very important. Then again, sequencing. Sequencing, sometimes we give neoadjuvant, chemo or radiation first and then take up for surgery. Because definitely there again, there will be difference in survival. See, sometimes the neoadjuvant treatment will work better than a post-operative adjuvant treatment. So when we downsize the tumor and then take up for surgery, surgery will be easier or sometimes in radiation will be challenging, but more than that, finally the patient survival that counts. So the timing of treatment, the sequencing, and then many other factors. Suppose once we do the surgery, for them again they will face a lot of challenges because they will be dealing with a compromised patient in a poor general condition and the disease area, the surgical field will be hypoxic, which may not respond well, our anatomy will be altered. So like a lot of challenges are there. But on the whole, over a period of time, what we have learned all these years is the timing and sequencing with less complication matter the most in getting good results.